Journal Club for October 2024. We've returned to our usual last Friday of the calendar month scheduling. Before we begin, we acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. To that end, we have covered it in this gathering before, but it is worth a second review, that to better understand the land upon which we live and gather, the Mississaugas of the Credit have published a document attempting to resolve the inadequacy of the Toronto Purchase of 1805. I will post this document to the chat box for everyone to refer to later. We have two great presenters and presentations today. The first from our co-lead resident, a returning presenter and well-known to most of you, Dr. Natasha Lane, to present on conservative management of acute painful vertebral compression fractures by way of systematic review and meta-analysis. Natasha, please go ahead.
Okay, is that sharing okay? Yeah, okay, perfect. Okay. Oh, that's interesting. You guys do have just my slides?
Your notes.
You cannot. Okay. Not that I have some secret notes. So thank you so much for the introduction. I'm presenting the systematic review and network meta-analysis on conservative treatments for the management of acute vertebral compression fractures. And I'm actually just going to have to exit my talk. I apologize. Sorry, guys. Computer problems here. Really? Okay. Okay. I assume someone will pipe in if they can't see my shared screen. So this is a journal.
We do not have the shared screen.
You do not have it. Oh no. Oh no. How do I still struggle with this so far into life? Okay.
Okay.
And
it's loading.
Perfect. Okay. So this is the paper published in JAMA in September of 2024. Sorry, JAMA Network Open. I don't have any disclosures. So we're going to go through what we know, what the guidelines are for management of acute vertebral compression fractures. We'll go through the study itself, and then I'll fly through a critical appraisal that you can look at in more detail at your leisure when the slides are posted, and we can talk about whether or not this study is practice changing. So I always like to start with a case. This is a fairly standard patient for us to see. She's a 78-year-old lady, very mild clinical frailty, vasculopathy at home with mild cognitive impairment. She's on a fairly standard set of medications for this host of morbidities, and we're seeing her because she had an acute lumbar spine, onset of lumbar spine pain 2 days ago, and she's admitted to hospital where CT confirms a compression fracture at L2. And like we see most patients who are admitted with acute vertebral compression fracture pain, it can actually be quite debilitating. She's been unable to do her IADLs or her ADLs even at home because of pain. And I just want you to think to yourself, I think we've all seen this patient many times in our practice. I want you to think kind of your ladder of how you pharmacologic and non-pharmacologic interventions and how you treat her pain. And I challenge you to reflect on, what guidelines are you following and what actually is the evidence for maybe your standard protocol for how you treat acute vertebral compression fracture pain. I'll tell you the guidelines that I'm aware of are the Osteoporosis Canada guidelines. And so these guidelines essentially indicate that if you have acute vertebral compression fracture pain, teriparatide and calcitonin can sometimes reduce acute pain. They say that in the text. And they, of course, recommend if you have a recent, which they define as within 2 years, vertebral compression fracture with more than 40% height loss, or more than 2 fractures in a T-score less than 2.5. They suggest anabolic therapy. The Royal Osteoporosis Society in the UK, they actually have a whole guideline dedicated to management of symptomatic vertebral fragility fractures. So they go into a bit more depth. And they recognize, or they recommend a pain ladder that I think most of us are maybe familiar with, starting with Tylenol and then adding NSAIDs and then COX-2 inhibitors. And then if none of those work, then opioids. And they recommend that just within weeks 0 to 4. And then they say any pain that persists past that, which we know 50% of people who have acute vertebral compression fracture pain will actually continue to have pain up to 6 months later. And then they recommend transitioning to TCA's gabapentin. And they also have recommendations around who qualifies for consideration of vertebral augmentation. So this patient, in our case, actually would, if she had unremitting pain for 48 hours after we started treating her, and it was continuing to interfere with the ADLs. They also make non-pharmacologic recommendations, which I think are probably aligned with the kind of thing we would be thinking about for our patient. And then you can refer to this for your reference. It is the excerpt from the UK guidelines. I think it's really interesting if you look at the table here, like this actually kind of looks like that famous pain ladder where opioids are at every step, and we just distinguish between weak opioids and I guess normal opioids, which is I think we're probably moving away from as a field, but it still made it into this guideline. And then they recommend other adjunct pharmacotherapy, muscle relaxants, if you think there's muscle spasm. And they say there's insufficient evidence for calcitonin, and you have to make an individualized choice. And then non-pharmacologic therapies, they recommend against braces and taping. And then say there's insufficient evidence for other non-pharmacotherapy, including like local heat or ice. So the study that we're going through today, it is a systematic review and meta-analysis. The population are patients with acute vertebral compression fracture. And I'll flag right here, they actually didn't define what acute is, but the studies they included had people with acute fractures anywhere from 0 to 12 weeks out from their fracture. And they wanted to compare any conservative treatment modalities, including analgesics, osteoporotic drugs, and other pharma and non-pharma interventions to any other treatment or placebo. And their major outcome, their primary outcome, was short-term pain during activity in less than 4 weeks from onset of the fracture pain, and their secondary outcomes were any outcome related to pain. And they included RCTs or prospective comparative studies published after January 1996. And that date was chosen just because they thought studies before that were like not really reflective of current practice patterns or guidelines, and they didn't have limits on age or language. It was a systematic review. They did duplicate extraction. They did a risk of bias assessment. They used the Cochrane risk of bias tool for RCTs and the Newcastle Ottawa scale for the prospective comparative studies. They used the GRADE approach to appraise certainty of evidence. They did a meta-analysis with R. They did use random effects models, and they estimated standardized mean difference for effect size. And then they calculated P-scores, which go from 0 to 1, and they reflect the probability of one treatment being superior to the other. I'll note, like, this is in contrast with like more Bayesian statistics, where we would say like the probability of one that this treatment is superior to the other is superior based. It's a more, I would say like the more Bayesian approach is more nuanced, but they use P-scores. And then they did a sensitivity analysis by activity type, but they actually couldn't do a sensitivity analysis by risk of bias because most studies have the same risk of bias, which is intermediate. And they said there was an adequate sample size for funnel plots to look at publication bias. So this is the Prisma diagram. Essentially, they started with about 19,000 studies. screened 15,000, got down to 280 per full text review, and then 80 studies were included. 20 studies were included. The 20 studies included about 2,000 patients. Most of them actually went through the studies, looked like they were looking at patients in their 70s and 80s. 16 of the studies were in hospital settings, which I think is relevant. We don't all practice in hospital all the time. And all of the RCTs had this intermediate risk of bias, except for one high and one low. And all prospective comparative studies had good quality per the Newcastle Ottawa scale. And then just want to flag for the RCTs, most of the risk of bias arose during the randomization process, as well as due to deviations from the intended intervention. And all of the RCTs were evaluating pharmacologic therapy, and the prospective comparative studies did have some rehab interventions, as well as bracing and pharmacotherapy. And you can look at the Prisma. This is a teeny summary of the comparisons that were made within the included studies. So these are the results. I think it's worth flagging at the very top that they had very low to low certainty, or low to very low certainty, and that was based on the previously described limitations of the study. I also just want to flag just how little data there are going into this analysis. So if you look at the nodes, like even kind of the biggest nodes in the network diagrams are like 3 studies with 85 patients, or like, you know, look at like daily teriparatide, it's 1 study with 10 patients. So like these are very small studies and sets of studies that we're drawing conclusions from. For their primary outcome, they found that calcitonin was superior to NSAIDs, which is superior to placebo, and they found that teriparatide, bisphosphonates, opioids, and vitamin D supplementation were non-inferior to placebo, or non-superior to placebo. And you can see that here they didn't include the opioids or the vitamin D, but essentially this diagram shows that calcitonin and NSAID are the only ones that don't cross 0 for the standardized mean difference. So we would say these are the ones that I would say I trust these findings a little bit more, although all of the limitations we talked about as we were going through study analysis. And then for their long-term outcome, they found that, so they couldn't do a comparison to placebo for the long-term pain, which was an average of pain measured at like 11 weeks versus 0 to 4. Because there weren't a lot of studies with placebo comparison groups. So their comparison group for their primary analysis and this outcome was NSAIDs. Nothing was superior to NSAIDs, but the daily teriparatide and weekly teriparatide were superior to bisphosphonates for long-term pain. Again, just flagging the very small sample size that these conclusions were based on. And these findings were echoed in their analysis for like their p-value. So the highest p-value was for calcitonin, and then NSAIDs in the short-term pain management. Sorry, that's my email alert. And then the daily teriparatide and weekly teriparatide were better than bisphosphonates. And I think like whenever I see that there's like a kind of like, maybe we'll say like a low quality of evidence, or we're not sure if there's a significant benefit of an intervention, I like to think like, is it going to cause harm if we do it? Like, should we just try? And in the studies that were included, I would say actually like most of them are supportive of just trying, even though this is a really unclear whether there's significant benefit. But with calcitonin, 2 of the studies that examined calcitonin didn't have any side effects compared to placebo, compared to placebo. And then 12% of people in one study got mild symptoms like transient headache. And then another study, people had dizziness, more than placebo, and mild stomach upset, slightly more than placebo. So if someone's in crippling pain and like they can't do their ADLs, I think I'd probably like risk these side effects. we're not talking about the cost. That's a separate issue. And then remarkably, NSAIDs, the studies of NSAIDs didn't give them to people with like renal disease, certainly. But these studies only had one case of air quotes upper GI disorder, which I think speaks to one, how select their populations were, and two, how small the studies were. I'm sure if they did like a huge study with a huge N, they'd probably get a bit more GI bleeding, et cetera. And then teriparatide in the long-term group, very few side effects other than some nausea, vomiting, dizziness, and bisphosphonates, the standard side effects that we see with bisphosphonates. And they also talked about cleft formation in the vertebra, which is suggestive of like a necrosis of the vertebral bodies, which is obviously undesirable. So there was a very high incidence of that in one study. And then the critical appraisal, I'm going to just skim through. You guys can review these slides if you want at your leisure, but in terms of relevance, there were numerous weaknesses just in terms of the body of literature that they were able to draw on. And then they also didn't report effect modifiers across studies, which I would expect. It's probably due to the small N. They did all of the standard things for analysis in terms of like using the appropriate random effects, maintaining randomization, not doing like inappropriate comparisons. But again, they didn't report on effect modifiers, and they actually didn't report like the measure of heterogeneity, which I found interesting because they said throughout the study, like, oh, it's so heterogeneous. That's why like limitations, but they didn't actually report the heterogeneity. And then we already talked about how they ranked studies compared to each other using the P statistic, which is not the most favored per my understanding. I welcome all the meta-analysis in the room to offer their understanding. And then they were all funded by pharmaceutical companies, which they did state in their disclosures, but it's present. And then just huge evidence gaps. I think the biggest takeaway for me from this study is actually, it's less to do with like, okay, like now we can say calcitonin works, and more to say like, whoa, like there's really not a lot of evidence for the guidelines and what we do in clinical practice. So there are only 2 studies evaluating NSAIDs. There's only a single study evaluating opioids and RCT. And it had a null finding. And then there were no studies examining post-fracture denosumab or romosozumab and how those medications might affect pain. Very minimal reporting on quality of life and functional outcomes, which are obviously very important to our patients. So limitations, we already talked about. It didn't report patient characteristics or the distribution of effect modifiers. There was no power calculation in terms of their ability to detect significant differences in the primary outcome, and their no quantification of heterogeneity between studies. And this is no fault of the study authors, but there are just these tremendous gaps in the literature that make it really hard to draw conclusions based on a summary of the literature. But they did, I trust that they identified the relevant RCTs based on their described methods. They appropriately used random effects, and this was a really important research gap to fill. So in summary, this is a systematic review of 20 studies, about 2,000 patients. Most of the studies were at intermediate risk of bias, and there were some suboptimal analytic and reporting choices in the meta-analysis. No studies of Tylenol, denosumab, or romosozumab for management of acute or long-term pain and vertebral compression fracture, and then only 1 null finding from an RCT of opioids. Calcitonin and NSAIDs were better than placebo for short-term fracture pain, had reasonable side effect profiles. Teriparatide was better than bisphosphonates and had some benefit for longer-term pain reduction, but no benefit over placebo for short-term management. And vitamin D supplementation and opioids were no better than placebo. I keep saying opioids no better than placebo because I was surprised by this finding. And we'll just return. Oh, I see you, Dr. Goldis, you've raised your hand. I'm almost done, so we'll just well, you'll be first up in 1 minute. This is a return to the case. I want you to reflect back on like having reviewed the study. Is there anything that you would change to your initial management? My reflections are that based on this study, I would probably be more likely to initiate calcitonin. I always kind of was like, piffle, it's so expensive and it doesn't work. It doesn't have a lot of side effects and it might work per this analysis. So I'd be more likely to initiate calcitonin. probably less likely to initiate opioids, to be honest. I didn't realize that the evidence was so sparse in this area. For people who are admitted to hospital with acute vertebral fracture pain, because remember, most of these studies were people admitted to hospital. Obviously, in our patient, I would hold off on NSAIDs given CKD. I'd consider Tylenol, but I have a really low threshold to discontinue Tylenol. The patient kept saying, like, this isn't helping, it's not helping, which is a practice change for me because I do prescribe Tylenol like candy to anyone who has pain in the hospital. And then I would reach for teriparatide more, I would say, reflexively based on these findings for the 2 years, assuming that they don't have any contraindications, and then switch to bisphosphonates thereafter. And that leads to our question period. Dr. Goldlist, please. I'm going to exit screen sharing.
Fabulous presentation. Very impressive. I just want to reflect on what, at the dawn of evidence-based medicine, the Lancet did a series. I can't remember what they called it, but I interpret it as evidence-based medicine for dummies. And one of the key principles, they said, if it's a very common problem and it's a tiny number of patients in the study, don't bother reading it, because it means that the filter to get those patients means that they're not going to reflect your practice. And I think I found that to be true over the years from when I looked at things. So we can maybe ask some of the methodologists to say how a meta-analysis of multiple tiny studies would correct that. I can't believe that it would, because if they're all small, then they're still going to all have that same error, that bias of who they've included in the study. And I would agree. My experience with Tylenol is that if you're in a lot of pain, Tylenol doesn't work. However, it usually works in a different pathway than other pain medications. So it might be reasonable to continue it, hoping that if you give it regularly, you need less of the other medication. But I agree with you, as a primary thing for very bad pain, it doesn't work. Although there have been recent studies in emergency rooms, not with older patients necessarily, of intravenous Tylenol being as effective as NSAIDs and narcotics for acute pain. So that maybe that's something we should be considering.
Yeah, I think it's a really interesting point, and it's something that came up when I was reviewing the guidelines in this area, is that there's so many guidelines that I think we might apply in our mind to this setting, where, like, sure, there aren't a ton of guidelines specifically for acute vertebral fracture pain, but there are a lot of guidelines for acute pain management. And so, like, and they include vertebral fractures in that. And so yes, I agree. There are a lot of other hands up. I think that secondhand
Natasha, regretfully, I'm sorry, I'm going to have to interject for the interest of timing and to respect our second presenter. I will have to invite Murray. I saw a hand up, Michael Gordon and Jen Watt. I invite you please to share your questions and comments in the chat box. Karen De Silva also has a comment in the chat box, and Natasha, please do respond to Karen, Murray, Michael, and Jen if they do submit. But for the sake of timing this morning, a beautiful presentation, Natasha, generating a lot of discussion. I regret we need to move on. The second presenter, Dr. Sandrine Couture, is a first-time presenter at Journal Club. If you did not meet Sandrine at our summer barbecue, she is a graduate of McGill University Internal Medicine and Geriatric Medicine residency training. She has a special interest in orthopedic rehab and osteoporosis. In July of this year, she started a one-year geriatric medicine rehab fellowship with UHN Sinai. A warm welcome, Sandrine, to present on zoledronic acid during initial fragility fracture hospitalization, continuing on the theme of osteoporosis. Welcome, Sandrine. Please start. And again, I invite Jen, Murray, and Michael to submit your questions in the chat.
Okay. Are you able to see the slide? Yeah, perfect.
Okay.
So good morning, everyone. I'm very happy to be presenting this morning. So yes, I'm going to talk about zoledronic acid for hip fracture during initial hospitalization. And I have no conflicts of interest. And so the objective this morning will be to review the literature on the use of zoledronic acid in secondary prevention of hip fractures, then to introduce the study, go through a critical appraisal, and then discuss the bottom line and are we changing our practice based on this study. Why should we be talking about secondary prevention of hip fractures this morning? Why does it matter? I think because the outcomes speak for themselves. 1 in 3 hip fracture patients will refracture a hip, refracture within a year. And then 22% of women and 33% of men will die within a year of a hip fracture. And in terms of additionally to these outcomes to the patients, it's also a big impact on the healthcare system. So the average cost to the healthcare system in Canada following a hip fracture in the year is around $64,000. And despite knowing all of this for a long time, in Canada overall, we're not really good at managing these patients post-fractures. And so this is data from the Public Health Agency of Canada from 2018-2019. And I had the chance to be at the Fragility Fracture Network meeting on Tuesday where they presented the 23 data and hasn't changed significantly. But within the year after having a fragility fractures, only 15% of patients, Canadian patients over the age of 40 get a BMD, and only 21% overall get a prescription for an osteoporosis medication. And compared to women, men are even more under-investigated and undertreated. So overall, there remains a big osteoporosis care gap in Canada. Zoledronic acid for hip fracture secondary prevention is not a new idea. Zoledronic acid got its big seal of approval when the Horizon Recurrent Fracture trial was published in the New England Journal of Medicine in 2017. And this was a randomized controlled trial where they compared zoledronic acid 5 milligram infused within 90 days of a hip fracture. The median time was 6 weeks after the hip fracture to placebo. And there was a 35% risk reduction of any clinical fracture in this study. There was also a significant decrease in vertebral and non-vertebral fractures, and there was also a 28% mortality risk reduction from any cause. So then the idea for giving zoledronic acid in the imminent post-op setting, the main published studies are from a group at Harvard at Massachusetts General Hospital, and this was from 2022. It was the QI study where they implemented a new fracture liaison service at Massachusetts General Hospital. And they also got this idea that they would give zoledronic acid inpatient during the index hip fracture hospitalization for the patients that they thought would be very high risk of not being able to present to outpatient osteoporosis follow-up in the future. And so before the intervention, 6% of the patients were on osteoporosis treatment within 6 months of their hip fracture. And following the combined intervention of the FLS with inpatient ZOL, potentially 39 patients of eligible patients were treated at follow-up, and 26% of the treated patients were treated through the zoledronic acid given as inpatient. So in terms of the safety of giving and the efficacy of giving it as inpatient, we have some prior data about this. So primarily from analyses of the Horizon RFT data. And so the first study was from 2009, where they looked at the BMD gains for the patient in Horizon RFT based on the timing of when they got the zoledronic acid. And so there was a greater increase in BMD at 12 months, both at the total hip and femoral neck when the zoledronic acid was given later than 6 weeks after the fracture. But all of the patients significantly increased their BMD at a year, and except for a group who had gotten it within 2 weeks of the fracture. And one of the limitations of that data was in Horizon RFT, only 56 patients got it within 2 weeks, so it was very small numbers. And then in 2011, there was another study then looking at more the clinical outcome of delayed union of the fracture. And there was no difference in delayed union in the patients who got the zoledronic acid versus the placebo. And there was similar rates of delayed union when it was administered early. So it didn't seem like in Horizon RFT that the early zoledronic acid affected the fracture healing. And then in terms of the immediate side effects, so the Harvard group at Massachusetts General Hospital who's been doing this published in 2023 an observational study of the immediate side effects of giving zoledronic acid as patient. And so in this study, they included 285 patients, and there was 204 who got the inpatient zoledronic acid. And so the side effect, the main concern is the acute phase reaction after the Zol. So 15% of patients got fever when they got zoledronic acid versus 4% in those who didn't. But there was no concern for a change in creatinine and no symptomatic hypocalcemia in this study. And so in terms of the patient selection, I think there is this concern that zoledronic acid can precipitate hypocalcemia or may not be appropriate in older patients who may have lower renal function. And so a group in France did a study on their orthogeriatric unit where they looked at, based on their population, they were admitting who would actually be eligible to get it as inpatient. And so it's a single center study. They had 136 patients over the age of 75 who were hospitalized with a hip fracture at their unit. And then when they looked at all of these patients, 81.5% had no contraindications to get zoledronic acid during that inpatient admission. One caveat is that the threshold that they use for the vitamin D that they considered safe are a bit different. So I think in Canada, we would probably wait for a level of 50 before giving zoledronic acid, but they were comfortable going lower in these French patients. So this brings us to our study. The PICO question for our study, the population was patients over the age of 50 who were hospitalized in the Massachusetts General Brigham System Hospital with an acute hip fracture. The intervention was zoledronic acid 5 milligrams given during the index hospitalization. The comparison was no osteoporosis medications in the first year post-fracture. And then the outcome, the primary outcome was all-cause mortality. And then the other outcomes were the subsequent new fractures up to 2 years after the index hip fracture. So the design of the study was target trial emulation. And so what is target trial emulation? It's when there is a research question that would ideally be answered best by a randomized controlled trial, but when a randomized controlled trial in this case is either not ethical to do or it's not feasible. And so in our case, it would not be ethical in 2024 to omit treating the osteoporosis of patients after a fracture for an entire year. And so doing a real RCT design would not be ethical. And so how they do target trial emulation is the first step is they fully create a protocol of what would the ideal RCT be. And then they will go through observational data and they will simulate every element of that RCT using that observational data. And then they have to use a statistical method to adjust for the confounding and to simulate as if there had been randomization between two groups. So we're going to go through all these elements as we look at the methods of the study, and that will make it maybe more clear. So in terms of the first thing they have to decide is what are the eligibility criteria. And so if we look here, what in the target randomized control trial, I'm not moving enough, sorry. So in the randomized control trial, it would be patients admitted with a hip fracture for surgery at the Mass General Brigham System hospitals between January 1st, 2016 and March 15, 2023. And the lab profile to be included would be a vitamin D level that's normal based on the US units. We use nanomole per liter instead of nanograms per ml here. A creatinine clearance over 35, no post-op AKI, no post-op hypocalcemia, and with the exclusion criteria of high trauma fractures that are non-fragility fracture, pathologic fractures, periprosthetic fractures, atypical femur fractures, patients under 50, and patients who are already treated for their osteoporosis. And so when they emulated the trial, they selected similarly all the adult patients who were admitted for hip fracture surgery at those hospitals between the same dates. they were able to extract all the baseline characteristics, the labs, the medical history from the MGB healthcare system database. That was the research patient data registry that's quite extensive at their institution. And then they confirmed that there was an index hip fracture, both by the OR reports and the radiology reports. And they confirmed this information by some random and also as needed chart review. So the next step in emulating the trial was to determine this treatment strategy. And so in an RCT, it would be zoledronic acid during index hospitalization in the intervention group, and then no anti-osteoporosis medications during the first year after the fracture. And so in the emulated trial, they had the same intervention. That's how they selected the groups. The next step was to assign the treatment. So in an RCT, they would have randomly assigned the patients to either inpatient Zol or no treatment based on the 1-to-3 ratio. And so in the target trial, emulated trial, they propensity matched the patients who received inpatient zoledronic acid and the untreated patients at a 1-to-3 ratio based on their clinical profile at the initial hospitalization. And so for matching, they used what would be major characteristics, either associated with poor outcomes such as mortality, and also as with the probability of receiving zoledronic acid. So the biochemical parameters, the vitamin D, the creat, the calcium, and then they used age, sex, BMI, race. They used the Charleston Comorbidity Index as well for a measure of comorbidity. And so they accepted standardized differences of less than 0.1 for the balance of the measured covariates. The next step was to determine what would be the start and what would be the end of the follow-up. So in an RCT, they would start the randomization at the index hip fracture hospitalization, and they would end at death, loss to follow-up, or March 15, 2023, whichever came first. And this is essentially what they selected as well in the emulated trial. They did time 0 of the emulated trial at the index hip fracture hospitalization, and the end of the follow-up was the same. In terms of the outcomes, so for RCT, the primary outcome would be death of any cause, and then the other outcome, radiologically confirmed new fractures, which were the same outcomes in this emulated trial. And then in terms of an analysis plan, for an RCT, they would have used an intention to treat analysis. And so in the emulated RCT, they used an intention to treat analysis as well. And they used a Kaplan-Meier method for distribution of time to the primary outcome. And then they used Cox proportional hazards regression analysis for the hazard ratio of death and new fracture. If we look now at the results of the study, this is the flow chart for the emulated trial. And so they identified the potentially eligible cohort in the database that has almost 12,000 patients. And then there were 743 patients who were the new users of zoledronic acid, and then 11,000 patients who hadn't gotten treatment. So they applied all their exclusion criteria. And so in the end, they were able to match 652 patients who had gotten inpatient zoledronic acid to 1,926 untreated patients for this 1-to-3 matching. These are the baseline characteristics that they use for the propensity score matching. And so all of the characteristics they had selected had standardized differences under the 0.1 that they accepted. And so if we look at the patients, the mean age was around 80, so similar to the patients we'll see with hip fractures, primarily female population, which unfortunately is hard to get an osteoporosis study where there's an equal amount of men and women. They all had normal vitamin D because they had to be selected in the data, and their Charleston Comorbidity Index, the mean was 5 in both groups, so patients who did have comorbidities. And if we move to this next table, this is in the supplemental material of the trial. It looks at other clinical variables, such as smoking status and other comorbidities that were not necessarily specifically adjusted for in the trial. But we can say that in the cardiovascular comorbidities, the malignancies, smoking status, the two groups were also well balanced after they matched the two cohorts. So if we look now at the mortality outcomes, so to the left, This is the graph for the mortality data in all of the patients. And so there was a hazard ratio of 0.62 that favored zoledronic acid compared to the no treatment, and that was statistically significant. And then if you go to the right, so zoledronic acid technically would be a yearly medication, and they analyzed their outcome at 2 years. But they did find that a lot of the patients actually only got that one dose as inpatients and did not receive a second dose as outpatient for their treatment. And so 585 patients only got one dose for 2 years. And so they looked at mortality data with just one dose, and that was still a hazard ratio of 0.7 favoring zoledronic acid. And that was also statistically significant with a little bit of a wider confidence interval. So then what they looked at mortality data in different subgroups. So first at the top, there's the mortality data by sex, where it was significant in women with a hazard ratio of 0.56 favoring ZOL for women. That was significant. There was no significant differences in mortality if they just looked at the subgroup of the men, which was also a smaller number of patients. And then at the bottom, you can see when they looked at the subgroup by age, so in the population under 90, and then in the population above 90. And so the zoledronic acid was a significant decrease in mortality in the younger than 90 group with a hazard ratio of 0.6. And again, there's a smaller number of patients that were above 90 in the study. So the next outcome were for incident fractures. And so at the top on the left, we have vertebral fractures, incident vertebral fractures. And so for vertebral fractures, the study favored zoledronic acid with a hazard ratio of 0.4. That was statistically significant in the entire cohort. And that also remained statistically significant when they only looked at the patients who got one dose over those 2 years, again, with a bit of a wider confidence interval. And there was no significant difference between zoledronic acid and the untreated patients when they looked at non-vertebral fractures and when they looked at contralateral hip fractures. So that's the bottom graph. In terms of adverse outcome, there was no difference in the rate of non-union between the zoledronic acid group and the untreated group, with around 1%, and that was not significant. And there were no cases of atypical femur fractures or osteonecrosis of the jaw in the trial. So if we move on to the critical appraisal and the risk of bias assessment, I used the Robbins Eye tool. And so it's a tool that has 7 domains. So the first domain is bias due to confounding. And so the first signaling question is if there potential for confounding of the effect of the intervention in this study. And so probably yes. If we go through the other questions, we'll see that there were a lot of adjustments that were made, but thinking of confounders that are potentially associated, you would think of potentially socioeconomic status could dictate whether someone would get zoledronic acid and could also dictate increased risk of adverse outcome mortality, or mobility data, frailty, which may prompt someone to get more zoledronic acid and may also associate it with fall risk and fracture risk in the future. The second question was whether the analysis was based on splitting the participants' follow-up according to the intervention received, and that was not the case. Then did the authors use appropriate analysis method that controlled for all the important confounding domains? I did say probably yes. So they used propensity score matching to where they included all of the most variables that would determine whether someone, mainly those biochemical parameters, whether someone would get inpatient zoledronic acid. And also the way they were able to design the study is that zoledronic acid was only given at one of the institutions where that FLS had piloted this project, and all the other hospitals were not giving zoledronic acid as their standard practice. So that's essentially how they were able to get the two groups. And the authors did mention that other than having that FLS intervention, the patient populations from the two hospitals would otherwise be identical. And it's not something that would, when someone has a hip fracture, they wouldn't be aware of this difference in treatment between the centers. And so then I answered yes, that the measures that were controlled for were measured properly. And so they had robust data for all the biochemical parameters and the demographic parameters in their database. And there was no post-intervention variables that could have affected the intervention. The second domain was bias to the selection of the participants. And so I'm sorry, for confounding, it was a moderate risk of bias. And now for the second domain, so the characteristics of the patients observed after the start of the intervention did not affect the selection of the participants. And the follow-up and the start of the intervention coincided for most of the participants. So that was a low risk of bias for the second domain. The third domain was bias in classification of the intervention. And so the intervention groups were clearly defined. The information used to define the groups was recorded at the start of the intervention. And the classification of the intervention status was not affected by knowledge of the outcome or risk of the outcome. So that was a low risk of bias for this domain. The fourth domain was bias to deviations from intended interventions. And the signaling question was whether there were deviations from the intended intervention beyond what would be expected in usual practice. And so the answer for that was no. One of the thoughts I had when I was reviewing the trial is that there was a co-intervention essentially in the group receiving zoledronic acid, which was that all of these patients received calcium and vitamin D with zoledronic acid. So there were more patients on calcium and vitamin D in the treatment group than in the untreated group. However, based on this bias tool, because this was an intention to treat analysis and they only looked at the effect of being assigned to zoledronic acid, then co-interventions do not have to be taken into account in the bias assessment. The fifth domain was bias due to missing data. And so the signaling question is, were the outcome data available for all or nearly all participants? And the answer probably yes. So mortality data was available for all of the patients. There was fracture data available for most of the questions. They did mention that they may have missed some fracture outcomes if they were in X-rays imaging centers that were not accessible in any of the public database, but they did censor the follow-up of the patient based on their last assessment in the MGB hospitals to try to account for that. And they did have measures to account for missing data. No participants were excluded based on missing data, and patients, well, so this was a low risk of bias for this domain. And then the sixth domain was bias in measurement of the outcome. And so the outcome measure here was measured quite robustly with radiologic reports. So the outcome measure was not influenced by the knowledge of the intervention. It's not clear, however, in the trial if the assessor were aware of the intervention received by the study participant. That was the second signaling question. And the methods of outcome assessment were the same in both groups. And there's no systematic error in measurement of outcome that was related to the intervention received. So that was overall a low risk of bias for this sixth domain. And the last domain was bias in selection of the reported results. And so the reported effect estimate, is it likely to be selected on the basis of multiple outcome measurements within the outcome domain? I said no, there were quite large specific outcomes, mortality, new fractures. And there was not multiple analysis of the intervention outcome relationship. They really followed the analysis plan that they had set in the protocol. And the different subgroups, well, there were different subgroups that were done, but that was all planned in the protocol before the analysis. So that was a low risk of bias. And so overall, in terms of the risk of the bias of the study, the highest measure was moderate risk of bias based on the domain 1 for the confounding. So that gives the score, the assessment for the overall study. In terms of the results, the sample size, there was a sample size calculation that was provided that was based on the difference in observed crude mortality rates for all the potentially eligible patients in the entire study period. and they were able to match enough patients to meet that sample size calculation. In terms of the effect size, we have a mortality, the hazard ratio was 0.62, and for the vertebral fracture, 0.4. Those were both statistically significant, and I would argue that those are both also clinically significant. And then in terms of the external validity, the limitations, so first of all, the generalizability. This is a single center study from a single hospital system in Boston. It's also a primarily white population. It's a primarily female population. And there was no data on the mobility, the function, the frailty to really determine if those patients are really similar to the patients we see in our centers. In terms of feasibility, so first I put cost reimbursement, which I'm going to come back in a second too. And then the second is something also that an orthopedic surgeon was talking at the conference I was at on Tuesday, who practices in the US, and would say that with this acute phase reaction in their center, it would trigger these code sepsis call on call with the patient being febrile, needing to get a sepsis workup. And so that can potentially trigger some anxiety and increased use of resources to investigate these patients who are having their adverse effects while they are inpatients. In terms of the cost, it may not be such an issue of cost, but more of an issue of where the money is coming from. And so this is a table from BC. I could not find a table of Ontario data, but that compares the cost of all the osteoporosis medications. And so we very commonly will initiate a PO bisphosphonate while someone is in rehab or at the end of their hospitalization. And those PO bisphosphonates are quite cheap. So the regular Zoledronic is $110 for a year. So for the couple of doses, someone will get, For the couple of doses that someone will get as inpatients, it's a couple of dollars, $10. If we go to the Zoledronic DR, it's actually $565 a year. So it's almost 5 times more than the regular Zoledronic. But if we think few weekly doses, still a fairly cheap intervention when it comes from the hospital budget. But if we were to give zoledronic acid all at once for the full year in the hospital budget, in terms of a couple of dollars or $10, now we talk about $360 upfront. So that may be a barrier for hospital funds to reimburse it as inpatient compared to a PO bisphosphonate. In terms of the external validity, so the feasibility based on cost was a limitation, but I think still globally, it's a feasible intervention with our current infrastructure. It's a medication that's widely available in Canada. Most of our patients who are post-op do have IVs, and we have the nursing support to give an IV infusion that's a 15-minute medication. So it is something that's feasible in our hospital system. So the bottom line, the administration of zoledronic acid during index hip fracture hospitalization is associated with decreased mortality and risk of vertebral fractures at 2 years with no evidence from increased risk of non-union. The study had a moderate risk of bias due to potential for confounding, and it's a feasible intervention in our healthcare system. And so I would say maybe not an intervention that we should change our practice and do for everyone, but particularly for the patients where we don't think will present for follow-up for osteoporosis management, or our patients where we may think their life expectancy may not be clearly a year, 2 years, or they're going to long-term care. Then if we treat them right away as inpatient, then they're covered for the next year, and we know we've treated them. These are references. Any questions?
Thank you so much for such a wonderful and great first presentation at Journal Club, especially with coordinating, keeping the lights on as well. I have a comment from one of our clinical pharmacists at Sunnybrook. This initiative is going on medicine on our floors here. They are doing a quality improvement project to implement zoledronic acid in this patient population. And our pharmacist says that the zoledronic acid cost is not a barrier for us. The cost can't be shared, but it has been genericized, and the low cost now allows us to support the work going on to our medicine floor. I have two more questions. One, Peter first, and then John. Go ahead, Peter.
Hey, Sandrine, thanks for the presentation. I just had something that I would have never known previously without like going to some level of grad school. And if I'm saying anything that sounds crazy, you just let me know, or the clinician scientists let me know as well. But the point at which you should decide treatment or not should be your time zero, not the time in which you were included in the study. So a true randomized trial would select everyone who had hip fracture and then randomize their time zero as whether they receive zoledronic acid or not. And in this study, their time zero was the hip fracture. So you can imagine if someone, for example, lived for 30 days in hospital and got their zoledronic acid at that 30-day point,
Right.
incorporated 30 days of living. And that would carry forward when you're doing your hazard calculations. So even do survives like selection bias, essentially. And we don't know in this study how long they've actually were staying in hospital, presumably for some period. I know the time period of the study is like 2 years, so maybe it doesn't affect it as much. But just to be wary of when you're critically appraising these studies.
No, that absolutely right, that there is potential for this immortal time bias at the time, because it's not super clear in the study when they mention like index hospitalization at the time zero, but they don't specifically say exactly which point. It seems like it's post-op, but is it when they got the dose? It's not super clear.
Thank you. Wonderful. Thank you, Peter, so much for your comment. Go ahead, John.
Oh, thank you. That's a wonderful presentation. So a quick point. Back in 2007, I was involved with the original frail fractured hip program that continues now to help with rehab. At St. Mike's, Dr. Earl Bogosh of orthopedics picked up on this very exact point, and was a big advocate of zoledronate post-hip fracture because of all the points that you had mentioned today. And back then, it looked like the rates of treatment went up. So here's the question about our behavior after the evidence is all there. What's happening now? Is St. Mike's the star and most people are getting treatment, or has the wheel turned again and we've forgotten this point? Does anybody have a sense of what's going on at St. Mike's? Because he was a big advocate there of doing this very thing 15 years ago.
I think one of the issues with hip fractures is that in Canada, we don't have national registries or provincial registries where we can all be aware of what other hospitals are doing. But I heard that Ontario Health is actually coming up with a registry that's going to be available for hospitals, hopefully starting in the spring. And I think that's going to help understand the landscape of what's going on with the treatments of hip fractures, and potentially push institutions to collaborate and try to adopt strategies that may work elsewhere.
That's great. We actually back then had reached out to Johns Hopkins, which I'm sure you know, had a massive registry now, probably 35 years worth of data. And we were advocating 15, 18 years ago that happened. It's so good to hear that it's taking less than 20 years. Thank you.
So that brings us to the top of the hour. I'd like to thank again our presenters today, Dr. Natasha Lane and Sandrine Couture, for just remarkably excellent presentations, and give us a lot of food for thought over the course of the rest of the day and going forward, managing your osteoporotic fractures, vertebral or hip. I echo Peter's applause. The evaluation link for today's Journal Club session should be arriving in your inbox shortly, if it has not already arrived. Thank you everyone for joining. We will see you next month.